lens anatomy. Now lens is a transparent, it is a transparent biconvex crystalline structure, placed between the iris and vitreous in a saucer shaped dispersion. This is known as the patella fossa. Here, known as the patella fossa. The diameter of lens is 8.8 to 9.2 mm. Thickness at birth is 3.5 mm. Thickness at birth is 3.5 mm, and at old age it is 5 mm. Radius of curvature, anterior surface is 10 mm, that is less convex. When radius of curvature is more, it is less convex. Posterior surface is 6 mm, so it is more convex. Okay, where lesser the radius of curvature, more the convexity. Refractive index of lens is 1.39. Accommodative power, dioptric power is 16 to 20 diopter. Accommodative power at birth is 14 to 16. 25 years it becomes 7 to 8, and by 50 years it becomes 1 to 2 diopters. Lens capsule, it is thicker over the anterior surface. Lens capsule thicker over the anterior surface than the posterior surface, and it is thickest as the pre-equatorial region, that is 14 micrometer, and thinnest at the posterior pole, that is 3 micrometer. Here it is thickest at the pre-equatorial region and thinnest at the posterior pole. Here anterior epithelium, then it is made up of lens fibers. It is made up of then anterior epithelium, lens fibers. The nucleus central part contains the oldest lens fibers. Here, okay, the nucleus contains the oldest lens fibers. Nucleus contains the oldest lens fibers. Central part, it contains the oldest fibers. Nucleus contains the oldest fibers. Fibers of fetal nucleus meet around the sutures, which are anteriorly Y shaped and posteriorly inverted Y shaped. See, fibers of fetal nucleus meet around the sutures. Anteriorly it is Y shaped and posteriorly it becomes inverted Y shaped sutures. Cortex is the youngest lens fibers. Nucleus is the oldest and cortex is the youngest. Cortex is the youngest lens fibers. Then next, coming to suspensory ligament of lens, that is the sonules of Sinn or the ciliary sonules. The fibers, these are the fibers passing from the ciliary body to the lens. It holds the lens in position. Okay, holds the lens in position. Now coming to canal of Petit, it is this is the canal of Petit. This is a Petit's canal. That is the space between the anterior and posterior suspensory ligaments of lens. Space between anterior and posterior suspensory ligaments of lens. Ligaments in the five. Next, coming to cortex. Cortex is a metabolically most active region, and composition of lens is 65% of water and 35% of the protein, which is the highest protein concentration among body tissues, and 1% there is lipids, others like lipids, carbohydrates and trace elements. Lens grows in size continuously throughout life. Okay, throughout life it grows in size, lens. Now factors responsible for lens transparency, it is avascularity, then the tightly packed nature of the lens fibers. Lens fibers are tightly packed. The narrow lens fibers membrane, loss of organelles, then arrangement of the lens protein, semi-permeability of the capsule, pump mechanism of the lens fiber membrane of lens fiber membrane, auto-oxidation and high concentration of glutathione. Reduced glutathione is present in lens. Okay. Next, coming to congenital and developmental cataract. Here it can be different. It can be of different types. First is anterior capsular cataract or a posterior capsular cataract. Anterior capsular cataract, it is non-axial, stationary, and visually insignificant. Non-axial, stationary, and visually insignificant. Posterior capsular cataract, it is associated with persistent hyaloid artery remnants. Okay. Then next is anterior polar cataract. Anterior polar cataract can be anterior pyramidal cataract or reduplicated cataract, that is double cataract. Next can be a posterior polar cataract. Posterior polar cataract can be due to persistent hyaloid artery remnants, Mittendorf dots, posterior lendicornus, or persistent hyperplastic primary vitreous. Next is nuclear cataract, that is because of rubella infection in the mother in the first trimester. This is a picture of Mittendorf dot. This is posterior polar cataract. This is anterior polar cataract. This here is anterior polar cataract. Here, cataract. Then here this is a posterior polar cataract. Posterior cortical, coronary, subcapsular, and pyramidal. This is a pyramidal reduplicated anterior polar cataract. Pyramidal, subcapsular, nuclear, and lamellar cataract. Nuclear cataract is because of coming to nuclear cataract. Nuclear cataract is because of rubella infection in mother in the first trimester. Cataracta centralis pulverenda is there. Embryonic nuclear cataract. It is autosomal. In nuclear cataract, it can be due to rubella infection. Then the next one is cataracta centralis pulverenda. Then the next one is total nuclear cataract. These are the three types of nuclear cataract. Rubella infection is usually in the first trimester. Cataracta centralis pulverenda, or also known as embryonic nuclear cataract, it is autosomal dominant, and there is bilateral powdery appearance of opacity. This is embryonic nuclear cataract. It does not affect vision. Okay, this is embryonic cataracta centralis pulverenda. It does not affect vision. The next is total nuclear cataract. It is dense white, chalky, central opacity. It impairs vision. There is seriously impairing vision. Bilateral and non-progressive. Next is lamellar and or zonular cataract. It is the most common type of congenital cataract presenting with visual impairment. It is autosomal dominant type associated with vitamin D deficiency, hypocalcemia, maternal rubella infection between 7th and 8th week of gestation. Occurs in the zone of fetal nucleus surrounding the embryonic nucleus. There is small linear opacities like this, like spokes of wheel. That is riders, may be seen towards the equator. Next is sutural and axial cataract. These are a series of punctate opacities. Scattered around anterior and posterior Y sutures. Scattered around anterior and posterior Y sutures. It is static, bilateral, and do not affect vision. Okay, does not affect vision, and static. It is static, bilateral, and do not affect vision. It can be floriform type. Floriform type is it is opacities are arranged like flowers of petals of a flower. That is floriform type. Or it can be coralliform type in the form of a coral. Coralliform type in the form of a coral, or a spear-shaped cataract in the form of scattered heap of shining crystalline needles like this. That is spear-shaped cataract in the form of scattered heaps of shining crystalline needles. Next is anterior axial embryonic cataract. This is anterior axial embryonic cataract. Then it can be generalized cataract like coronary cataract or blue dot cataract or total congenital cataract. In coronary cataract, it is developmental cataract occurring around puberty. Developmental cataract occurring around puberty. Hundreds of opicities are distributed radially in the periphery. This is coronary cataract. Corona of club-shaped opicities is known as. Vision is unaffected. The opacity is distributed radially in the periphery. That is coronary cataract. Corona of club-shaped opacity is known as. Next is blue dot cataract or cataracta punctata cerulae. This is the most common type of congenital cataract. There is punctate opacities in the form of bluish dots in the periphery of adolescent nucleus and deeper layer of cortex. Then we have the total congenital cataract. It can be hereditary or due to maternal rubella infection. In rubella cataract, child is born with the pearly white nuclear cataract. In rubella cataract, okay, it is a progressive type of cataract. Lens matter may liquefy and the lens matter can become soft and liquefy. It is known as the congenital Morgaginian cataract. Then we have the congenital membranous cataract. Here there is total or partial absorption of congenital cataract, and it leaves behind a thin membrane like this. That is congenital membranous cataract. It is associated with Hallermann Streiff Francois syndrome. It is a total or partial absorption of congenital cataract leaving behind a thin membrane cataract. Next, regarding indication and timing of pediatric cataract surgery. For visually insignificant cataract, follow-up non-surgical treatment with pupillary dilatation can be done. For bilateral dense cataract, we usually do it within 6 weeks of birth. Second eye operated within few days after first eye. For unilateral dense cataract, it is done as early as possible, within days after birth. Prognosis is usually poor. In order to prevent amblyopia, we do this. Okay. Surgical procedures is this thing is like pediatric is anterior capsular excess and irrigation aspiration of lens matter, lensectomy is done. Needle operation was done before, now it is obsolete. Next, coming to acquired cataract. First is age related or senile cataract. It is the most common cause of acquired cataract. After 70 years, more than 90% of the individual develop senile cataract. In more exposure to UV rays may result in early onset and maturation of senile cataract. Smoking is associated with nuclear cataract. Usually bilateral, one eye is affected earlier than the other. Morphologically, it can be cortical, soft or nuclear hard cataract. Now cuneiform is a cuneiform variety. Wedge-shaped opacities in the periphery can be seen. Cuneiform is the most common type, followed by nuclear and then cupuliform, which is 5%. Mechanism of loss of transparency in cortical senile cataract is there is decreased level of total proteins, amino acids and potassium, increased level of sodium, and there is marked hydration of lens, that is increased water content of lens, marked hydration of lens, and coagulation of proteins, lens proteins. This is in cortical senile cataract. Now coming to mechanism of loss of transparency in nuclear senile cataract, it is due to intensification of age related sclerosis, dehydration and compaction of nucleus, and increase in water insoluble proteins. Insoluble protein. Coming to maturation of senile cortical cataract, maturation there are now coming to maturation of senile cortical cataract. First is the stage of lamellar separation. It is the earliest change, is a demarcation of cortical fibers. Earliest change with demarcation of cortical fibers. It is demonstrated by slit lamp examination only. Okay, so only by slit lamp examination we can see this, demonstrate these changes. Changes are reversible. Changes are reversible. Then next is stage of incipient cataract. Here there are two forms, cuneiform variety and cupuliform. Cuneiform is wedge shaped opacities. Wedge shaped opacities starts in the periphery, usually in the lower nasal quadrants. Visual disturbance are noticed at late stages here. It is a wedge shaped opacity in the periphery. So, the visual disturbances are noted in the late stages as center is still clear. Next is cupuliform. Cupuliform is a saucer shaped opacities. Okay. Cupuliform is saucer shaped opacities. Saucer shaped starts in the central part of posterior cortex. Central part of posterior cortex known as the posterior subcapsular cataract. There is early loss of visual acuity because it is located near the nodal point here. Because it is located near the nodal point, there is early loss of visual acuity. Patients are characteristically troubled by glare, and symptoms are increased by miosis, that is constriction of pupil, because the location of the opacity is in the center. Such miosis such as it occurs in during near visual acuity or in bright sunlight, etc. Then next stage is immature senile cataract. Here the lens is greyish white lens, and sometimes the lens becomes swollen, then it is known as intumescent cataract. When it is swollen and becomes intumescent cataract, the AC becomes shallow. So, it will become phacomorphic, it can lead to phacomorphic glaucoma. Then next stage is mature senile cataract or ripe cataract. It is here we have a pearly white lens. There is no lens shadow and no light. There is no lens shadow, but light perception will be there because light perception is a retina function. Okay. Then hypermature, next is hypermature senile cataract. It can either be Morgangian hypermature cataract or sclerotic hypermature cataract. In Morgangian hypermature cataract, the cortex liquefies and the brown nucleus, the cortex liquefies and the brown nucleus settles at the bottom, leading to phacolytic glaucoma, which can lead to phacolytic glaucoma. Or there can be sclerotic hypermature cataract. Here the lens shrinks and anterior chamber becomes deep. There is iridodonesis, that is tremulence of iris. Tremulence of iris will be there, lens will shrink and anterior chamber will become deep. Maturation of next is maturation of senile nuclear cataract. Here the changes begin centrally and then spread to the peripheral region. Nucleus may become diffusely cloudy grayish to tinned due to pigment deposition. Amber or brown color, it is known as amber or brown color, it is known as cataracta brunescens. When it is black, cataracta nigra, and rarely reddish, then known as cataracta rubra. Now coming to etiology of secondary cataract, there are numerous causes for secondary cataract which can be divided into systemic disease, toxic agents, dermatological causes and physical factors. Systemic disease include the most common is type diabetes mellitus type 1 and 2. Other causes like hypoglycemia, hypoparathyroidism, myotonic dystrophy, galactosemia, Alport syndrome. Different syndromes like Alport syndrome, Lowy syndrome, Stickler syndrome, Down syndrome and Treacher-Collins syndromes are the systemic disease. Toxic agents include corticosteroid, acetylcholine esterase, chlorpromazine, busulfan, chloroquine, amiodarone, cigarettes, copper, iron, gold can all cause secondary cataract. Dermatological, it includes atopic dermatitis, ichthyosis. Physical factors include trauma, UV rays, electric shock. Clinical features, glare, that is intolerance to bright light. This is the earliest symptom. Then there is uniocular diplopia due to irregular refraction, and there is colored halos due to water droplets in lens. Other symptoms include black spots in front of eye, then image blur, distortion of vision, misty vision. Patient with central opacity, that is cupuliform cataract, they see better. These people, cupuliform central opacity, that is cupuliform cataract, these people will see better when the pupil is dilated, because in the center there is opacity. They will see better when the pupil is dilated, that is day blindness. Patients with peripheral opacities, that is cuneiform cataract, visual loss is delayed. Vision improves in bright light, that is pupil is constricted. Okay, in patients with nuclear sclerosis, that is distant vision deteriorates due to progressive index myopia. Such patients may be able to read without presbyopic glasses, which is referred to as the second sight, because of progressive index myopia. Now the common cause of anterior capsular cataract includes gold, chlorpromazine and Vossius ring. Anterior subcapsular cataract include diabetes mellitus, hypoparathyroidism, galactosemia, miotics, electric shock, atopic dermatitis. Posterior subcapsular cataract, it includes diabetes mellitus, hypoparathyroidism, again galactosemia, then myotonic dystrophy, radiations, glass blowers, that is infrared cataract, infrared radiations, high myopia, atopic dermatitis, steroids, neurofibromatosis 2, hereditary fundus dystrophies can predispose to posterior subcapsular cataract. Now coming to complications of cataract, there can be phacoanaphylactic uveitis, that is lens protein leak into anterior chamber in hypermature cataract. Or there can be subluxation or dislocation of the lens due to degeneration of sonules in hypermature cataract. Or there can be lens induced phacogenic glaucomas, known as phacogenic glaucomas. Phacomorphic glaucoma can be there, phacotopic or phacolytic. Phacomorphic is swollen intumescent lens, intumescent cataract. Phacotopic is anterior displacement of lens. Hypermature cataract. Or phacolytic due to the trabecular meshwork. Here the trabecular meshwork is cloaked by lens protein, also seen in hypermature. That is phacolytic cataract. Now coming to next one, complicated cataract or secondary cataract. Complicated cataract or secondary cataract. These are chronic anterior uveitis is the most common cause of complicated cataract or secondary cataract. Typically it starts as posterior subcapsular cataract usually. It has this particular breadcrumb appearance or rainbow cataract or polychromatic luster, that is a characteristic. This is a complicated or secondary character having the characteristic breadcrumb appearance. Now there are certain cataract like associated with systemic disease, trauma, radiation association. Sunflower cataract, this is a sunflower cataract. It is seen in Wilson's disease and or chalcosis. That is sunflower cataract. Next is a snowflake or snowstorm, which is seen in juvenile diabetes mellitus. Usually more common in juvenile diabetes. This is a snowflake or snowstorm cataract. It is due to the accumulation of sorbitol, glycation and carbamylation of crystallines. It can also be seen in Down syndrome. Next is a lamella cataract. This is a lamella cataract. It is seen in hypoglycemia. Next, rosette shaped cataract or blunt trauma. This is a particular rosette shaped cataract seen in blunt trauma. There is this osseous ring. There can be this osseous ring also in case of blunt trauma. We'll see osseous ring on the anterior surface of lens. Then this Christmas tree cataract. This is a Christmas tree cataract. This is a Christmas tree cataract seen in myotonic dystrophy. Oil droplet cataract seen in galactosemia. This is oil droplet cataract seen in galactosemia. Blue dot cataract. This is a blue dot cataract seen in hypoparathyroidism or vitamin D deficiency. Shield cataract is seen in, this is a shield cataract seen in atopic dermatitis. Shield cataract seen in atopic dermatitis, or the glass blowers and next is the glass blowers or the glass workers cataract. It is due to infrared heat radiation. These are the glass blowers or glass workers cataract. This is a secondary or complicated cataract. Next is pre-op evaluation for cataract. In pre-op evaluation, we have to do anterior segment evaluation, posterior segment evaluation and objective test for evaluating the retina. And then there is a macular function test. In anterior segment evaluation, specular microscope examination of the cornea for endothelial count. Specular microscope examination of cornea for endothelial count is done. Presence or absence of keratic precipitates should be looked for in anterior segment. Then evaluation of lens morphology and maturation of cataract should be looked for. Morphology and maturation of cataract. Then in posterior segment evaluation, B scan gives valuable information regarding the posterior segment, such as the vitreous and retina in cases with total cataract or when there is no view of cataract, we can do B scan. Objective test for evaluating retina include electroretinogram, electrooculogram and visually evoked response. Now next is macular function test, which include projection of rays to test the function of peripheral retina. Then there is two light discrimination test, Maddox rod test, color perception test, entopic visualization. These are the macular function test. Now coming to various techniques in cataract surgery. First we will discuss about intracapsular cataract extraction. Intracapsular cataract extraction. This here has the name suggest entire lens is removed. Entire lens along with capsule is removed. The prerequisite is weak and degenerated nodules cannot be employed in patients with less than 40 years where sonules are strong. It can be performed in 40 to 50 years by using the enzyme alpha chymotrypsin, which dissolves the sonules. Only indication nowadays for ICC is marked subluxation or dislocation of the lens. Subluxation or dislocation, marked subluxation or dislocation. Other than that, it is absolute actually, it is not done now. Then also for maskil operation like eye scan, what it is absolute, not done nowadays. Next is ECC, that is extracapsular cataract extraction. Here major portion of the anterior capsule with epithelium, nucleus and cortex is removed, leaving behind intact, leaving behind intact posterior capsule before IOL implantation. It is a surgery of choice for almost all types of adulthood and childhood cataract, but now more commonly it is SIC is preferred. Then here the most dreadful complication is expulsive choroidal hemorrhage. And the incision is around 10 to 12 mm incision. Now coming to small incision cataract surgery, it can be done for all types of cataract including grade 4 and 5. It is easier than phacoemulsification, not machine dependent, less operative time, cost effective, less complication than ECC. Coming to phacoemulsification, next one, here topical anesthesia sufficient in expert hands and minimal postoperative congestion, minimal postoperative complications like congestion, corneal complications and astigmatism, minimal complications. Steps: here a clear corneal incision of 3 mm is made using a keratome and continuous curvilinear capsular access is done, then followed by hydrodissection, emulsification of lens, aspiration of cortical lens matter and then IOL implantation. The disadvantages: it is difficult to learn, long learning curve, difficult to learn, machine dependent, then high cost, difficult to deal with grade 4 and 5 cataract. Then here nuclear drop is a dreadful complication. In spite of few demerits, phacoemulsification is a preferred method for cataract extraction now worldwide. Next, micro-incision cataract surgery is there. Phacoemulsification can be performed through micro-incision in less than 2 mm. Phaco, that is micro-phaco done with a needle incision technique. Needle incision technique less than 1 mm. Next is femtosecond laser assisted cataract surgery. Femtosecond laser, it is the best available procedure as of now. Basically a manual micro incision cataract surgery with femtosecond plus femtosecond laser to perform. Next is nucleus management in cataract surgery. Nucleus management in ECC, the nucleus is delivered by enlarging the incision up to 8 to 9 mm. Depending on the nucleus size, degree of hardness and malleability. Now in SICS, a 4 to 6 mm incision, tunnel incision is made and the nucleus is popped out. In phacoemulsification, nucleus is emulsified using a machine. Next is intraocular lens. Intraocular lens first implanted by Harold Ridley. First implanted by Harold Ridley in November 29, 1949. Commonly used material commonly used is PMMA material, polymethyl methacrylate. Now there is iris supported lens, PCIOL, that is posterior chamber intraocular lens. This is a usually this PCIOL. This is a iris supported lens. Okay, this is a iris supported lens. Here you can see this iris supported lens is there. Then PCIOL it rests behind the iris. Recent trend is in the back fixation. Commonly used model is modified C loop. Modified C loop is commonly used. Then here rigid IOL is made entirely of PMMA. Foldable IOL is implanted through a smaller incision, that is 3.2 mm after phacoemulsification. It is made of silicone, acrylic. Mostly it is acrylic. Most common is acrylic. Also hydrogel and polymer. Rollable IOL, it is ultra thin IOL. Ultra thin IOL is implanted through a micro incision 1 mm after phaco-knit technique. Phaco-knit technique made of hydrogel. that is rollable. In anterior chamber IOL, this is an anterior chamber IOL, you can see here, anterior chamber. This is an anterior chamber IOL. It lies entirely in front of iris. Can be inserted after ICC and or ECC. ICC or ECC. There is higher incidence of complications like bullous keratopathy or UGH, uveitis glaucoma hyphemia syndrome. Next is IOL power calculation. Its biometry involves two parameters, keratometry and axial, that is anterior posterior length. Okay, keratometry is a determination of the curvature of anterior corneal surface. Optical coherence biometry, it is a non-contact method of axial length measurement. ACE can less accurate method of determining axial dimension. Now SRK formula is there. SRK is Sanders-Ritzlaff-Kraft formula for calculating IOL power, which is P is equal to power is equal to A minus 2.5 L minus 0.9 K, where A is power of IOL, L is axial length of the eyeball in mm, which is determined by the A scan, K is average corneal curvature defined by keratometry. Next, coming to complications of cataract surgery. Cataract surgery complication can be divided into intraoperative, early postoperative and late postoperative, or preoperative, intraoperative and postoperative. Every step has a complication. Preoperatively complication can be small pupil, pupillary synechiae, that is attachment of the pupil, posterior part of the pupil to the lens, like attachment of the posterior part of the pupil to the lens. Otherwise, sonular laxity dialysis, capsule will be fragile, vitreous prolapse, vitreous coming to anterior chamber, shallow anterior chamber, deep anterior chamber, glaucoma. Intraoperative, while doing surgery, iris damage can occur, posterior capsule tear can occur, capsular bag dislocation can occur, vitreous loss can occur. Postoperatively, uveitis, posterior synechiae, capsular phimosis or IOL dislocation, endothelial cell damage, cystoid macular edema. There are numerous complications for cataract surgery. Every step will have a complications. Now coming to after cataract or secondary cataract, again this is also a complication of cataract surgery. Opacity which persists or develop after ECC. Opacity which persists or develop. Okay. Now sombering ring is a thick ring. This is a sombering ring. It is a thick ring of cataract. Thick ring of cataract formed behind iris. Okay, behind iris. Next is Elschnick's pearl. These are the Elschnick's pearl. It is a vacuolated subepithelial cell. Vacuolated subepithelial cells that are clustered by soap bubbles along the posterior capsule. Treatment with a thin membranous cataract, then we do a thin membranous, we do a YAG laser capsulotomy. Dense membranous, this is thin membranous. In dense membranous, we have to do surgical membranectomy. But most commonly, we do a YAG laser capsulotomy. This is the most common. Okay. Now, coming to IOL related complications, there can be cystoid macular edema, UGH syndrome. There can be corneal endothelial damage, uveitis, secondary glaucoma with iris supported. It is usually seen in iris supported IOLs, or sunset syndrome, that is inferior subluxation of IOL, or sunrise syndrome, that is superior subluxation of IOL, or lost lens syndrome, that is complete dislocation into vitreous cavity. Windshield wiper syndrome, when a very small IOL is vertically placed in the sulcus. When a very small IOL is placed vertically in sulcus. Or there can be toxic candidate syndrome, toxic candidate segment syndrome, TAS, that is uveal inflammation, uveal inflammation excited by either ethylene gas used for sterilization of IOL, either by ethylene gas which is used for sterilization of IOL, or by the lens material itself, can cause toxic candidate segment toxic candidate segment syndrome, TAS, that is the uveal inflammation. Now next is congenital displacement of lens. It can be single ectopial lenses, that is bilaterally symmetrical displacement, usually upwards, or that can be ectopial lenses et pupillae. This is ectopial lenses et pupillae. Here displacement of lens is associated with a slit shaped pupil which is displaced in opposite direction, that is ectopial lenses et pupillae. Slit shaped pupil displaced in opposite direction. Okay, displacement of lens associated with slit shaped pupil which is displaced in opposite direction. Now ectopial lenses can be associated with systemic anomalies, like in Marfan syndrome the displacement is to superior temporal part, homocystinuria it is inferior nasal, Weil-Marchesani syndrome inferior sublunar section associated with microspherospheric, that is Weil-Marchesani. Other syndromes include Stickler syndrome, Ehlers-Danlos syndrome, hyperlysinemia, sulfite oxidase deficiency. These are ectopial lenses associated with systemic anomalies. Next, coming to lendiconus, there is a anterior or posterior pole assumes a conical shape. Anterior or posterior pole assumes conical shape. Anterior lendiconus associated with Alport syndrome. Alport syndrome, these features of Alport syndrome you should remember. There is familial hemorrhagic nephritis, sensory neural deafness, and oil globule reflex on direct ophthalmoscopic examination. Then there is posterior lendiconus. It is associated with Lowe syndrome. Lowe is oculocerebrorenal syndrome. That is about anterior and posterior lendiconus.